Thanks so much, Dr. Debbie. Can you hear me?
Yes.
Okay. So after that, I feel a bit emotional. Thanks for that, Dr. Debbie. Yeah, it was really a team effort, and I think I must start with everything good that has happened to me is thanks to my teacher, Professor Mike Satege. And then, of course, everything that didn't quite work out is because I didn't listen to him. So I'm sure you don't envy me because I'm the last speaker. I'm just before lunch. You're tired now. There's a beautiful day outside, but please bear with me. Okay, so I start with an outline to just, actually I should have been an introduction to Prof. Mike's talk. What is actinium PSMA? Because we talk about this, we're not all nuclear physicians, so I'm just going to take a few steps back to go to the basics. And then, is it any good? But where's the catch? How do we treat? What makes it a bit hard to treat? And what can we look forward to? So we've highlighted that prostate cancer is an important problem. And if you look at Africa, and particularly South Africa, you can see that the incidence rates there are quite high. It's the dark blue. So you can see we're among the top spots really in the world in terms of incidence rates of prostate cancer. And then if we continue to look at the mortality rates thereof, you can see that there we are the clear winners in Africa. The dark red shows you the mortality rate compared to the rest of the world. And clearly Africa is in a different league for various reasons that we've already mentioned today. And some of it being the particular genetics in our populations, the differences in the genetics. And so we're all convinced that this is a big problem. Now, what is actinium? It's a radioactive isotope with a half-life of 10 days. And as it decays, each time it emits 2 alpha particles and 2 beta particles. And as you can see, there's also some gamma emission there, which I'll refer to slightly later. Right. So this alpha particle, what makes it wonderful, to me the best things in sliced bread really, is that you now come close to the tumor. There's the DNA of the tumor, and you break both strands of that DNA. And so now, of course, the tumor struggles to regroup and regrow again and metastasize. So in fact, you're really coming close to the DNA, the center of the tumor. You're throwing a bomb at it, and you're killing it. So alpha particle therapy then gives you over a short range, gives you a high energy radiation. So if you take this and compare it to lutetium, for example, you have 100 kilo electron volt per micrometer versus 0.7. So you can imagine the difference in radiation damage. So then what is PSMA? Our prostate cancer, of course, we've spoken about this, gives us a nice target now, which goes across the cellular membrane and allows us to give things that can be internalized into that tumor cell and to attack it really from the inside. So just to go to the basics again, if we look at the PSMA, we have the prostate cancer cell here, we have the PSMA that gives us that nice big target, and then we link this to a peptide, and the peptide is linked to something that makes it radioactive. So we could either make it radioactive to see with our PET CT camera, so then we label with gallium-68 or fluorine-18, or alternatively, once we've seen it, we can now change that to lutetium or actinium. We've spoken about theranostics a lot, which is just like a mashup of therapeutics and diagnostics. And so it's wonderful if you can see the disease everywhere, so to find it, and then to substitute that radioactivity for a treatment one, then to fight it, and then also to see, is it working or not? So now we can monitor the treatment response with our imaging. So when we talk about any drug, those are usually the principles that hold. You want it for the right patient, you want the right drug at the right dose, right route of administration, and at the right time. And for actinium, most of these are still quite uncertain. So we know the dose more or less, we know it's IV. We don't quite know where it fits into the landscape yet, and I'll go into a bit more detail. But important is that our patient is at the center of this, and it's a multidisciplinary team, which is why all the various disciplines are here today. You can see that for diagnosis, nuclear medicine doesn't feature at this point, let's say yet. And then primary staging, from primary staging to biochemical recurrence to castrate-resistant prostate cancer, the nuclear physician is an integral part of the team. But you can see the people in the room are well represented. I didn't see on Prof. Ntambirua's slides the nuclear medicine physician. I wanted to point it out. That's an omission. Okay, so I'm doing a bit of revision of what Prof. Mike has nicely demonstrated. The alpha particle, then the one that we use in actinium. The beta particle is the one we use for lutetium. And then how we decide, it's based on so many factors really. It's where you have the art of medicine and the science of medicine coming together. And we look at things like how big is the tumor. And when you target different kinds of tumors, your peptide has to match your radioactive part so that it doesn't lose each other in the process. It has to be well matched. And then it has to be internalized so it can come as close to the tumor core as possible to destroy the DNA. Okay, so we are very thankful to our colleagues in Heidelberg who started all of this and determined the doses that we use today, which is 100 kilobecquerel per kilogram. And that was determined by seeing at which point do you get a response and not severe side effects. So it's a risk versus balance. And if you go higher than that, you don't necessarily get a better response, but you start getting more side effects. So this is the work on which all of our subsequent work has been based. And you can see that that was quite remarkable. In a group of 38 patients, demonstrated 87% of them demonstrated some decrease in serum PSA. And of those, 63 was actually more than 50%, which is quite impressive. And then if you look at the median tumor control time of 9 months, that also compares quite well to the conventional therapies. What I really like about this group is this, the way they represented it, to show you, if you look at all these colors, the light blue, for example, is abiraterone, the dark green is actinium PSMA. So if you look at where it happened in the treatment landscape, it's always right at the end. And then it also shows you the length of that line, shows you how long did it control the tumor for. And if you can now consider that this is the last thing you've used, and looking at those months that are actually very comparable to some of the very conventional drugs, that says a lot. It makes you think that if you were to put this earlier in the treatment, what would happen? And of course, we'll get to that. So then, my esteemed Professor Mike Sotege and the group that I was a part of then, we looked at the predictors of overall and disease-free survival in these patients with metastatic castrate-resistant prostate cancer when we treat them with actinium. And so this was a group of 73 patients in which 83% demonstrated a serum PSA response, and of those 70% demonstrated a response even greater than 50%. And if you look at that estimated median survival time of 18 months and a progression-free survival of 15 months, that is quite impressive. Also, what was found is that this decline in PSA tells you which ones are going to respond yes or no. So the better it is initially, the more it falls that PSA, the higher likelihood the patient has of doing very well. Just to show you some of the side effects there, I'll show more slides of the side effects because nothing just has good effects. Dry mouth, as what I am having now, which I'm just going to cure quite quickly. So the vast majority of them get a dry mouth, around 80% of them. You'll never forget this now. The other side effects tend to be, it could be dry mouth, dry eyes, or bone marrow suppression or kidney. But almost all of our patients in Pretoria had quite a dry mouth. And that's quite a difficult thing to treat, which I'll get to. But you can see the rest of it, if you look at the grading of it, it stays more or less around grade 1 or 2. You don't really get worse toxicity in terms of the grading there. Right, so now if you just look at the PSA decline again, you can see the vast majority of them had a significant PSA decline. And this is of course the way we want to measure it according to the prostate working group 3. And you can see that the ones who had a less than 50% decline did not live as long as those who did. The predictors then is that intensity of the drop, but any PSA decline is a good sign. So then of course we had to wonder, if you now use it as a last resort and still get this wonderful result, why not move it closer to the beginning? So this group of patients either declined chemotherapy or they were not fit enough to receive chemotherapy. And so as you can see there, group A was the ones treated with conventional therapy, and they had 71% decrease in tumor markers. Whereas if you go to the treatment naive ones, you get a 92% decrease in tumor markers, which is quite impressive. And then looking on the other side to the side effects, you didn't quite see a difference between the two groups, which is very encouraging. So then the curiosity continued to go to the post-ADT setting. And this is one of the most recent prizes that Prof. Mike got. This one is the most cited article. Any PSA response in 91% of patients. I think we can all agree that is quite significant. And then undetectable in 1 out of 3 patients. Quite amazing. So, of course, again, the decline in serum PSA of more than 50% was significantly associated with a longer overall survival. The bottom line really is that a PSA decline of at least 50%, a low pre-treatment platelet level, and the response according to RECIST or PERSIST is significant predictors of a longer progression-free survival. Again, just to show you that the side effects really don't go beyond 1 or 2, grade 1 or 2 mostly. And so the conclusion is then that it's a viable treatment option in this setting of post-ADT, especially if you don't have other options, which is really the theme of nuclear medicine often, which we hope to change to bring it earlier. Now, if we start looking at the meta-analysis appearing, they start to include more studies. This one is a fairly recent one in the JNM, which included 9 studies and 216 patients. And we can start seeing that those initial results from the smaller studies are now really confirmed, all showing really, you can see the more than 50% decline in, let's say, around 60% of patients in this forest plot, and any PSA decline of around 80 or above 80%. Just to look at that mean progression-free survival and overall survival, it's between 9 and 11 months. To show you again that now from the latest combined evidence what the side effects are, we still have the grade 1 or 2 dry mouth, and the anemia of grade 3 or 4 in a small percentage of patients. Thrombocytopenia and leukocytopenia also quite low in percentage. And so the evidence is mounting really for actinium PSMA. I'll just show you all of the meta-analyses that have been appearing lately, but all of them say there's an excellent serum PSA response and patients suffer from xerostomia. That is the bottom line. So now, because we are visual creatures, I'm going to show some images, and this was from my previous home in Pretoria. So this patient, you can see, started with a PSA of 6.7. All of these are metastatic lesions. Was treated with 8 megabecquerel. Responded. So then we tended to de-escalate. So we started using less and less actinium to spare the salivary glands and the kidneys and the bone marrow, and to really just target the tumor. Decreased to 7 again, and you can see this is an amazing response. Within a year, you've gone from this picture to that one. And then if we look at something that looks more or less like a super scan, with a PSA of 782, after just 3-4 cycles in a space of a year, you've gone from this image to that one, and a PSA of 0.04. Just two more impressive responses from Pretoria. So if you look at this one, patient with, you can see there's obviously huge lung metastases. Patient has metastatic prostate cancer with lesion for +3, and there are really no options left for this patient. And you can see that after one cycle, do you see this? That is quite amazing. There's nothing there, there's hardly anything there. And then similarly, a patient with a brain lesion, you can see mostly people would not operate on that. One dose of actinium and the patient was cured. Again, thanks to Prostate. So just to summarize again, the side effects, we've spoken about that again and again, but grade 3 nephrotoxicity is something people are often worried about, because in 3%, the bone marrow toxicity, anemia 1 in 3, and then the xerostomia. And what can we do about this now? So we've tried various strategies. We started with cooling these salivary glands, which really did not quite work. It seems like you have to really cool down those salivary glands for a significant amount of time and really, really cold. And it's not just based on vasoconstriction. It's also the biology within the salivary glands that creates the PSMA retention and uptake. So vitamin C sprays, all of it has been tried, and there's no real answer yet. Probably it will be that we find a PSMA that has a better biodistribution, so it doesn't go to the salivary glands in the first place, or we encapsulate it like Prof. Mike mentioned. So how do we select these patients? So for now, we look at those patients with metastatic castrate-resistant prostate cancer who has exhausted, declined, or they're not eligible for any other conventional treatment options. If that is yes, now we say, okay, we need to see this first. We need to image with a PET-CT or a SPECT-CT. And if that receptor expression is enough, so we say 2 times the liver intensity, but significantly more than the liver, and it's widespread and metastatic, then we can treat, provided that there is no contraindication. So now we look for any contraindications. So is it ECOG 0 to 2? Yes. Is the white blood cell good? Is the platelets above than 75? Is the EGFR more than 40? If that is all yes, then we continue. And now we select, looking at the image, is it more skeletal and widespread? Then we tend to go for actinium, Dr. Luso. And then if it is more focal and bigger lesions, then we tend to go more for the lutetium. As we mentioned, the lutetium gives you that longer range. It's like pointing an arrow at the tumor. And so you need a bigger tumor and fewer of them. So when we look at the practical aspects, it's an outpatient treatment. We give it once every 2 months. It's just a short injection. The patient goes home immediately after. There's no real preparation. And we see them just before the next cycle again. So we do the bloods and the images just before the next cycle. So many things are still not set in stone. We don't have quite good guidelines yet. So we try with preparation to hydrate the patient well. Sometimes you give steroids if there's maybe impending spinal cord compression. And we're still not sure whether to, when or how to escalate and de-escalate the doses. How many times can we treat? When do we retreat? Do we continue and combine with other therapy? It's all still being figured out. And of course, this brings us to tandem approaches. So we can do actinium combined with lutetium. And the advantage of that would be that you can spare the salivary glands to some extent. And there are various ways of doing that. So you can either do sort of a half dose of actinium with a full dose of lutetium, or the other way around, and increase and decrease as needed. Okay, so this brings me to the part that makes me happiest. To me, this was really a dream come true. At many points, I didn't think this was going to happen. You might have seen conflicting reports in the media that the first actinium in PSMA happened in private practice. I just want to correct that. It happened at Albert Lutuli Hospital and University of UKZN in January of this year. And we've since treated nearly 20 patients, and I'll show you some of the results. So if you look at this patient, the baseline there, you can clearly see it's widespread metastases and a PSA of 429. And then we treat it with one cycle of actinium PSMA. We start with 8 megabecquerel, like how my father taught me. And then you can see after that one cycle, that PSA dropped from 429 to 27. Look at that. Does make you happy. Okay, the next patient you can see had significant abdominal lymph nodes, 65-year-old lesion 4+3, and had 8 cycles of lutetium before. If you look at the follow-up scan, you can see the PSA drops to 15. And then the latest one looks like that with a PSA of 4.98. 3 cycles of actinium PSMA, meaning the patient had to come for 3 visits, go home, outpatient, pain is less, better quality of life. Am I selling this to you?
Really bought it.
Okay. So then, just need to show one more. This is not such an impressive in terms of the visual changes, but you can see that the PSA, okay, so this is real life now. We see the patient here, it's widespread metastatic disease. We decide actinium PSMA. We treat, and then the PSA goes up. We do see this every now and again. And sometimes the image also looks like it is getting worse, which is why often we leave out that first image, because it's just, it doesn't give a true reflection. And you can see the patient is getting better, but it's not reflected in anything else. And then you can see the next one then drops again. So after 2 cycles, now we're at 206, and it starts looking better on the scan. And then after 3, you can see that image, PSA of 45. And then the last one, which looks, if you look from this one to that one, that is quite remarkable. But more than that, I must say that these patients do better clinically, even if you don't see much of a difference on the image initially. Okay, so just to share with you another patient we've treated, a young 28-year-old with quite a different type of cancer, had no options left, and we didn't have access to the TKIs, so we treated with actinium dotatate, and you can see from those lung mets, after 1 cycle, how it decreased from that image to this one. So we spoke about, some of the previous speakers also spoke about the dosimetry and how difficult that is. You can imagine you give now 100 kilobecquerel per kilogram to every patient, but the lesions are different. So some lesions are big and they have a big nucleus, and others are small. So not every lesion is treated exactly the same, so some lesions will be undertreated. So it would be nice to see how you are doing in terms of dosimetry to image actinium PSMA. And you can see that this has been done using these gamma emissions that I mentioned before. And so we repeated it, I think yesterday or the day before. So this was the gallium PSMA PET. I'm just going to focus on the pelvis for now. But you can see this is the 24-hour images after therapy. And if you link that up to the PSMA PET, you can see that you can get an idea. So we can do some interesting work in this space. Before I get to the challenges, I just want to remind you of our patients, what they look like and where they're from, and how early they had to get up, probably like you did this morning, to get to us. So if you look at this vast province of ours, the size of Portugal, and you have to travel from there and there and there and there, from everywhere to this one spot in Durban. that already highlights some of the challenges. You can see it doesn't look quite comfortable in this situation. So the challenge is obviously the patient logistics. We need to be sure that if we book a patient, there will be actinium on that day. We can't let them come and then there's nothing. The fact that they present late and have a high burden of disease has got a plus and a minus, because those are the patients we can treat well with actinium. And then also, it's an outpatient procedure, so they don't have to be admitted, they don't get lots of side effects. We don't have to worry too much about bed shortages. But the main thing is to have a reliable supply, the availability and the reimbursement, and to start standardizing our protocols. So Prof. Mike has already done this. I'm just going to say that it will start to be a cycle, more or less, where you hand over to other role players, and you might need now immunotherapy, or you might need PARP inhibitors, or you might need to re-express the PSMA with upregulation through enzalutamide and abiraterone. So it's a combination therapy, which is what we've all said, and tandem therapy, and there's various new ways of doing this. So the future looks very bright. And then in summary, it's promising because we can see the improvements in overall survival and progression-free survival. Even if it's the last thing you do, we can minimize the side effects to make it even better, and start writing guidelines and start figuring out how we combine these treatments. And then, of course, we want global production and availability to all. And with that, I thank you, and I thank AAC Amersham, and I thank the Department of Health and the university, and really every single person who made this possible. I want to single out my wonderful team here. So that is the dream team. Thank you, guys. Thanks for everything you do, and in particular to Dr. Adebe. Thank you so much. Thanks. I'm ready for questions now.
One of the most frustrating things for me is, and some of my oncology colleagues are here, is in a patient who was in remission or adequately treated and the PSA is rising, and whether we do gallium PSMA PET-CT or F18 PSMA, we see nothing. And I think you understand in private how expensive these scans are. And it becomes a minefield for us to walk. So the question is, it was raised earlier about this neuroendocrine differentiation. Are we actually missing those ones where, for example, a PSA is 8 and it was previously 0.5? And now, no matter what we throw at this patient in terms of imaging, whether it's nuclear medicine or MRI, we can't see anything. So what should we be doing with these patients? Because the PSA keeps rising and we keep scanning and we see nothing.
Yeah, I wish I had an answer for you there. So Sonia, it's probably easier to image those patients than to try and... it'll depend on the histology that you got already. So if you know there's a neuroendocrine component, why not image with something that can detect that? But I can't give you a good answer.
And these are prostate cancer patients with the classical adenocarcinoma up front. So the question is, should you go back and look at the histology and see if there was a neuroendocrine differentiation, or at which point did this tumor...
Probably, I think so. And remember, you're just taking a sample, as we heard again and again. You don't know what the rest of the lesions look like. And which is why we want PET-CT, to look at the whole body and see what's happening. And as you heard, there'll be a new excellent tracer for that from Numerai. So watch this space then. I just want to, at this point, point out that there's a patient's daughter in the room. I don't know if you want to make a comment or make use of this opportunity to ask a question with everyone here.
So as Prof. Foster said, so my dad is 76 years old, and he has metastatic prostate cancer, and it was advanced quite a stage, and he's not a candidate for chemo, and he'd been on the on Xtandi, on Androquer, for a period of time, and it stopped working, and I was out of options, and the doctors that I'd seen in private, the oncologists were like, that's it. That's the end of the line. There's no more options. And I'd contacted, at the nuclear medicine department, and it was amazing that that I learned about this new therapy. And I was also hesitant about. I wasn't sure because it's something new. And my dad, he's been on this therapy since May, and his situation was quite bad, and he's done amazingly well. We were worried about symptoms and things, and he actually has done really, really well. He hasn't had any severe dry mouth or anything like that, and he went from being in a lot of pain to after the first treatment, his pain just like he stopped taking painkillers. He wasn't eating well. He started eating again, and it was just remarkable the difference it made just after one treatment. I was feeling a bit stressed because in there was the second dose was not available due to a supply issue, so it didn't come through. And then they'd given him lutetium, but he's had his second dose of actinium just last week, and he's doing really, really well. So I just would say thank you to the department, and everything has been he's been doing really well.
Prof, thank you for the presentation, and in fact it's really an opportunity and a privilege to just walk close to you, seeing all these changes happening within a short period of time in our center. I was just observing some few things. The response is amazing for the hopeless group that we are sending them home by telling them that, sorry, go and have just a best supportive care. For them to have such kind of wonderful opportunity is amazing in the medical era. However, I observed the side effect. And on that side effect, particularly I gave attention to the grade 3 and 4. Then pick up, I think, grade 3, some few renal impairment are coming in. And I was looking at the interval of the period the patients are getting cycle of the actinium. Perhaps are this group of patients being reviewed bit shorter than their cycle time, or they are being reviewed just to the second cycle? Because I am just footing a thought process that probably if this patient can be reviewed much earlier and address their renal impairment by some intervention, probably it may reduce the renal impairment in the future. But what is your thought?
So this renal question, we do check them before at baseline. So we do a MAC3 and we do the EGFR to check. And usually the ones who have impairment from the beginning are the ones who end up having the higher toxicity at the end. So we do try and manage them before we treat them. But it's that risk versus benefit. If you have impaired kidney function, but you really have no treatment options left, we do follow those ones more carefully. We still treat them, but we follow them up more quickly, and we refer them to urology for co-management. Does that answer your question? Okay.
I'd be remiss if I didn't ask you a question, because I'm still the talkolosh. First, I'd just like to thank you for Neanderthals. The simplicity of the talk has helped us as well, and congratulations on what you've done, all of you guys here. But now I'm going to tell you off. We all are buddies with. We're all buddies with Oliver Sartor and all these guys who did Vision. Can you tell me when are the phase 3s going to come out, and why is it going to have to require the trials to be done in America or something, or can we do that here and get the data? That's for all of you guys, basically. Yeah.
So in terms of, this is what we had been having with Novartis, as you could have seen, for instance, for the lutetium, it was North America and Europe only, not even Australia came even at the back, and some of the core centers, such as Heidelberg, were not necessarily included. But then this is what we are changing. So there is going to be another post-marketing for lutetium, but for actinium, we already are doing the trial, proper trial, and then there's going to be more phases that are going to come. And we are trying to say that, I mean, as they do it, it shouldn't only be in Europe, especially for the alphas. It will include the likes of also places like India and China, and which is what is important that we've been telling about. But unfortunately, we also have to say the industry sometimes, you know, they're thinking, I mean, are we going to get good data, are we whatever, and so on. But they are starting to realize that this is going to change. And of course, with that in mind, there's a formal trial that's going to, which we had been asking for, except for the therapy. They're putting gallium as now, you know, to determine your volume and as measuring the lesions, and so that is coming, and we will be part of it. But we cannot be part of it if we don't come as a group. That's the other thing that we had been a little bit weak on, and thanks for being in our guideline. But what is going to really help is really if we are going to come as cohesive and multi-center trials, which has helped Australia and Germany to do much better than what they were now, actually.
Sorry, what did you want? Yes. Oh, okay. I'm going to take it across there.
Thank you for a wonderful presentation. I have two questions. The first question is that so I'm assuming that these cases would generally be your typical adenocarcinoma, and then so I want to know, like, for example, do you have the other subtypes in your patients, or it's just only the acina subtypes? And then the second question is that so because these patients, they either get other forms of treatment earlier, and then they fail with the treatment, then you then come later because of disease progression. Prior to starting treatment, are they biopsied, or they are treated based on the initial biopsy, so that you know, for example, whether there was any change in the disease process between the initial biopsy and now when you start the treatment? Thank you.
From our cohort here is still very small, so we've only really seen adenocarcinoma. And I think it's not routinely really, they don't really go into the histological subtypes routinely. We just get a very broad outline of what the histology is like. There's not much detail. And as I say, we only have a small cohort so far. But even in Pretoria, I don't think we saw much else. We saw adeno.
We saw them just assumed by image, but they not necessarily reproving actually.
Yeah. And we definitely don't go back for biopsy again. It's just based on the initial biopsy.
Thank you. My question is to AC Amersham, please. When can we get actinium in the private sector? I understand that it's available, but you have to pay cash for it, and that medical aid is not yet approving. Could you tell me what the state is at the moment? Thank you.
Thank you, Doctor. Yes, it is available for cash-paying patients. At the moment, we are engaging with Medicredit because we need to find an EPI code for it. And we've submitted initially, and they've requested more data from our side, which we are gathering and submitting. So once that is done, then there is a code to claim with. Then the next level then it is with the funders. So we have also started with Discovery as well when we were having a discussion with them around the lutetium PSMA, because also that needed long motivations. So we started the discussion with them. So once we get the data sorted out that they've requested from the Medicredit side and we get the code, then we continue with our discussion with Discovery. But the process it has started, and soon we should have some positive news for you. Thank you.
Just to say, I think I have thanked everyone. I hope I have. I just want to highlight AC Amersham again for sponsoring this wonderful. Thank you so much, and Mpumi for all your organization. And then to say that I hope that you found this useful and that you learned something, and that we can really continue to work together. I think that's the most important. If we can continue to talk to one another and work better in future, that would be amazing. I think our patients would benefit greatly. Thank you so much for your time and being here, and I hope you enjoy lunch. Thank you.